Dr. Yashi Bansal for her talk on
A bit ignored topic in ophthalmology, that is ocular disorders in Parkinson's disease. So Parkinson's disease, as we all know, is a neurodegenerative disorder which is characterized by dopaminergic deficiency in the basal ganglia, and it encompasses both motor and non-motor symptoms. So the ocular disorders occurring in Parkinson's disease can be categorized majorly into three categories. The first one are due to degenerative process underlying the Parkinson's disease, that is due to dopaminergic deficiency, and these respond positively to dopamine therapy. The second ones are the ones occurring as side effect of dopaminergic, cholinergic or noradrenergic medications which we give in the Parkinson patients. And the third ones are the side effects occurring as side effect of surgical intervention like deep brain stimulation and pallidotomy, which are the surgical interventions for Parkinson patients. So what is the significance of identifying these visual disorders? So these visual disorders, they serve as prognostic factors for the progression of Parkinson's disease. Visual hallucinations, which are a type of visual disorder which is seen in Parkinson patient, is associated with a more rapid cognitive decline and is a significant predictor of dementia in such patients. So the use of visual cues such as stationary stripes pasted onto floor to alleviate freezing of gait, which is used in Parkinson's, this becomes difficult in these patients, and these patients, they suffer frequent falls. New rehabilitation strategies such as exergaming, smart glasses, telemedicines, they also fail to offer any help in presence of visual disturbances. So the presence of visual disturbances disrupts daily activities such as walking, reading or driving, and lead to decreased quality of life, as the patients with Parkinson's largely use visual cues to guide their movements. So timely recognition of these symptoms help in offering them independence and a better quality of life. So what are the various ocular disorders that are seen in Parkinson's disease? They are majorly grouped into oculomotor disturbances and diplopia, glaucoma, dry eye disease, color and contrast impairment, visual hallucinations, visuospatial and visuoperceptual impairments. So in oculomotor disturbances, we have convergence insufficiency which causes blurred near vision, then there is upgaze limitation, abnormal saccades and smooth pursuits. So diplopia, the prevalence is 10 to 30%, and it is majorly categorized into binocular diplopia or selective diplopia, which is a specific type seen in Parkinson patient. So the binocular diplopia is often seen and is caused by eye misalignment. Common cause of binocular diplopia is convergence insufficiency, where the eyes struggle to turn inwards to focus on near objects, leading to an imbalance of the visual axis. Selective diplopia, which is distinctly seen in these patients, it is where isolated objects or people, they are seen duplicated and the patient does not always sees double. So this is thought to be closer to the mechanism of visual hallucinations rather than an oculomotor problem. So the incidence of diplopia is directly related to the disease progression, and diplopia can also serve as predictive factor for the occurrence of visual hallucinations. The treatment in case of binocular diplopia that is associated with convergence insufficiency largely consists of prisms and convergence exercises, while the selective diplopia can be managed by managing hallucinations, and addressing the hallucinations is actually helpful in these cases. Then the prevalence of glaucoma is around 16 to 24%. The glaucoma can be open angle, angle closure or normal tension glaucoma. The most common of these is primary open angle glaucoma, but the prevalence of high intraocular pressure is less in Parkinson patients. The pathophysiology of glaucoma here is due to progressive retinal dopamine depletion leading to the retinal degeneration, or the alpha-synuclein mediated axonal degeneration, which is common in both glaucoma and Parkinson patients. The investigations are the usual ones which we do for glaucoma, that is fundoscopy, IOP measurement, visual field analysis. Treatment consists of topical anti-glaucoma drugs. If the patient does not respond, then laser trabeculoplasty can be done. But since the basic underlying mechanism is dopamine deficiency, so levodopa therapy can improve some visual aspects. Dry eye disease prevalence is 53 to 60%. The pathophysiology is decreased blink rate, which is a classical Parkinson symptom, which leads to decreased distribution of lipid components of tear film over cornea, leading to faster evaporation of the aqueous layer. Autonomic dysfunction, which is seen in Parkinson disease, also contribute to this, as lacrimal gland is partially innervated by parasympathetic autonomic supply. So the treatment consists of artificial tear drops, omega-3 or 6 fatty acids, punctal occlusion, temporary or permanent, can be done. Color and contrast impairment, exact prevalence is not known, but the most commonly seen ones are blue, yellow and red-green deficiencies. The pathophysiology consists of impaired processing of visual stimuli due to deficiency of retinal dopamine. Treatment consists of dopaminergic therapy and prescribing yellow filter glasses or selective absorption glasses to the patient. So visual hallucination, they occur early in the disease course in Lewy body Parkinson, which is a specific type of Parkinson disease, and helps differentiate this type from the other types. So the prevalence of visual hallucination largely ranges from 4% to 82.7%. These comprise of simple illusions like misinterpreting a quote as a person to complex, vivid or formed hallucinations of people or animals. So the visual hallucinations underlying cause is thought to be a nerve cell loss and Lewy body pathology in specific areas of the brain that affect vision. Visual hallucinations are more common in patients, those have dementia, and are associated with the accelerated cognitive decline. Anti-Parkinson medications, especially dopamine agonists and anticholinergics, serve as significant triggers for visual hallucinations occurring in these patients. Other health conditions such as infection or dehydration can also act as triggers. So the medication adjustment forms a very important aspect of treatment in case of visual hallucinations. Reducing or changing the anti-Parkinson medication can help, and prescribing atypical neuroleptics like quetiapine or pimavanserin can be helpful. Then we have visual spatial and visual perceptual deficits. These impairments are linked to structural changes and atrophy in the posterior temporal and parietal cortex, and dopamine deficiency contribute to these problems. So in conclusion, the neurologist or the treating physician should be vigilant about the ocular disorders occurring in these patients, because patients don't recognize ocular symptoms as a part of Parkinson disease diagnosis and don't report themselves. Ocular symptoms can be treated with ophthalmological intervention or optimization of dopaminergic therapy. Dopaminergic medication, deep brain stimulation and pallidotomy can contribute to the visual problems. Hence, a closer evaluation is required while switching from one mode of treatment to other. So in the end, I would say that data on ocular disorder in Parkinson is largely lacking. So a lot of research needs to be done to improve the quality of life and offer independence to these patients. Thank you.
I'm sure a lot of us don't have this experience that you have, because you need to work with in a big hospital or somewhere where there are a lot of neurological patients. But good that you took up the topic.
Yes.
Thank you.
Is the incidence of this glaucoma actually high in such cases, or is it the same as it is found in senile patients?
Sir, the incidence of glaucoma is around, like I said, 25 to 40%, but the incidence of high intraocular pressure is not there.
Is not. So it means it's a case of
the intraocular pressure remains low because the glaucoma is due to dopamine deficiency.
Dopamine. So it's basically normal tension glaucoma. We can say that it's ischemic component which may be responsible. Yes. And secondly, how this you just mentioned that diplopia sometimes serves as a factor for visual hallucinations. They are predictor of disease. How we differentiate and how they are helpful in such cases?
Sir, if visual hallucinations are present, if patient is reporting visual hallucination, then patient has more chances of developing diplopia.
Is it actual true diplopia, or is it visual hallucination, which is more common in such cases?
So visual hallucinations, like I said, the incidences ranges from 4 to 82.7%, and they are more common in Lewy body Parkinson disease.
Okay.
So it's like some patients can have more of.
So is it true diplopia?
Yes, it's binocular or selective diplopia.
Okay.
So monoocular diplopia never occurs in Parkinson.
That is not there. And the cause of binocular diplopia will be?
So convergence
Convergence insufficiency.
Yeah. Oculomotor disturbances are there,
Mhm.
so that leads to the bio.
Okay. Right.
Thank you.